Good morning, Bore da, everybody. My name is Andrew Jones. I'm Chair of UK PHR, and I'd like to give you a very warm welcome to our Practitioner Conference for 2021. I'm just going to say a few words of introduction and to lay out the sessions as they're going to happen today. And I know you've all had the same instructions that I had about using the facilities on the left-hand side and the right-hand side. And we really do want this to be a participative conference. So please do, when you have the opportunity, both network, but also ask questions of our speakers. So as I say, welcome. This is a really important conference for UK PHR. It's your and our opportunity to hear from inspirational speakers, but also to network with some colleagues and say hello virtually to friends and other practitioners. This celebrates UK PHR's commitment to practitioners and practitioner practice and registration across the UK, across the 4 nations of the UK. And it also highlights our important role as a regulator in protecting the public, in setting standards and supporting you in the work that you do. The conference is a virtual one, as we're experiencing, and who would have thought that 12 months on from the beginning of a global pandemic. But as you all know, and the conference recognises and will celebrate the role that you're playing in relation to this really difficult period. So I'd like to thank our sponsors first of all, because without those it would be very difficult to have done this. So Health Education England, the Health Foundation and Public Health Scotland, but also to thank you for giving up some of your time today to participate. And it's very clear that the pandemic continues to have a major impact on the global, but also our UK population health, not only from a health protection perspective and an infection perspective, but from social and economic well-being, with inequalities in health being laid very clearly on the table. Our theme for the conference today then is the COVID-19 challenge and how we're responding. And just on behalf of UK PHR, first of all, before we go into the sessions, I want to thank you all for the roles that you've been performing in this unprecedented time. I'm aware I'm the Strategic Director for COVID in Public Health Wales, and I'm aware just how much specialists and particularly practitioners have been inputting to our response to both protect and promote the health of our populations and local communities. It's an incredible effort. And we want to thank you for what you're doing in relation to this response, which is undoubtedly providing support to save lives, to protect and promote health. And I think that just highlights the importance of the public health workforce and as you as practitioners as a key part within it. So on to the day. We've got a structure for the day. As you know, we've got a plenary session to begin with. And then we've got conference sessions which enable you to join and then make a second choice. They're rerunning at 11 o'clock so that you can actually, if you're in doubt as to which one, you can choose another one to go to. At the end of the morning, we're then going to celebrate with our annual Innovation Awards. And again, I'd like to offer the chief executives and the UK PHR boards to all of those who will receive awards and all of those who participated as well, because without the participation, we wouldn't be able to make awards. So you'll see that virtually at the end, and we'll celebrate that in the normal way. So moving on to our first session then, and we really do want these to be interactive. So please do use the chat bar on the side to ask any questions. We're going to look at, in our first session, back at the COVID-19 responses and indeed how you as practitioners have contributed and also been supported. And as I say, we'll then go into the sort of parallel sessions, if you like, where you'll get to choose, and we'll just let you know when to do that. So first of all, without any further ado, can I welcome Youssof? Youssof is a Public Health Registrar to the Medical Director and Director of Health Protection in Public Health England, and he's going to talk about our look back at our response both globally and particularly in the UK. Youssof, welcome, and I'm going to hand the stage over to you. Diolch yn fawr, thank you very much. Okay, my apologies. It seems that Youssof hasn't managed to join us yet. Just bear with me 1 second, and we'll just understand whether or not we can move to the next speaker first. Thanks for your patience. Yes, I can. I've been asked to improvise for a few minutes. So, well, we're going to talk about COVID. Let's talk about UK-PHR. I hope UK-PHR is supporting you as practitioners. That's our intention. We know the pandemic has had an impact on everybody. Many of you will have been taking on new roles, and I'd also respect that, like me, like all of us, you've been dealing with the pandemic and its impacts on personal life, on family life, on education, as well as work and support to from a caring perspective. And I think we just need to acknowledge that in this unprecedented time. UK-PHR's intention very much is to support you as practitioners. And as you know, we've appointed a new chief executive in Marcel Boo. Marcel and I are meeting again later today, and he's chairing the conference tomorrow. And we're really committed to continue the role of UK-PHR, in particular in relation to the development and support of multidisciplinary practice, and particularly in relation to practitioner registration and practitioner support. I'd like to just take this opportunity to thank all of our volunteers who have continued to support UK-PHR, during the pandemic. We're not doing everything that we would have wanted to, but please be reassured as practitioners, we really do want to support you in relation to registration, and we'll hear on that sort of during the course of the next 2 days. So I'm understanding that Youssof is here, so you've heard enough from me. I'll speak to you again later on. Youssof, the stage is now yours.
Hello everyone, very sorry for the delay. I've had some tech issues, as is the want with virtual meetings these days. So I'm just going to try and share my screen so we can talk through the presentation. There we go. So I hope you can all hear me. My name is Youssof Oskrochi. I'm a public health registrar, and I've been asked to do a look back at COVID. Give me 1 second while I switch this to a different screen. Apologies. There, it should be working now. So I'm asked to look back at COVID, the highs and lows. And what I'm going to do is look at what's been happening across various countries. And this is going to be a very high level summary of the various responses, what has worked and wasn't worked well. And what I'll do is just go through some of my own personal thoughts, and I'd like to clarify these are my thoughts, and again, very high detail, and if people want to learn more about them, then I've put the references in the slides, and I do suggest that you delve into it because it's quite interesting and lots of lessons to be learned. So I think the best place to start is to look at South Korea. And if anyone was going to do a pandemic response properly, and if anyone wants to find out how the right way of doing a pandemic response would be, it would be to look at South Korea. Now, South Korea were, if you can be, in the enviable position of having had experience with a pandemic before. So the MERS outbreak in 2015 caused significant issues for their healthcare system, almost brought it to its knees. But as a result, there was an internal review, a national review, and a lessons learned document produced, which had 48 policy suggestions which were implemented. Some of the examples of things implemented included recruitment of hundreds of epidemiologists spread around the country, recruitment and training of IPC personnel, which were embedded around different organizations, and integration and seamless working between government, healthcare, and public health, especially the Korean Center for Disease Control. And actually, when you look at the timeline of their response, you can see that it was very quickly escalated and ramped up based on the findings and based on the lessons they learned from MERS. And you can see, and it helped the fact that Korea, obviously with its proximity to China, they had access to data much earlier, they had access to viral samples earlier, and also, which I'll come on to later, the wider determinants, their society, their legal system, the infrastructure in place also was conducive to a very effective response. So some of the things that happened in South Korea was there was a holistic approach to healthcare and the pandemic, i.e. the KCDC in conjunction with the Ministry of Justice, Ministry of Foreign Affairs, were able to coordinate the pandemic response. Quickly, they established treatment centers and quarantine centers, and as you can see, they look like holiday homes. So they look like places people may want to go and quarantine and not feel like they're being unduly kept isolated. Quickly stepped up their testing capacity, and I'll come on to the reasons why that happened later on as well. But also societally, there was a much broader acceptance of the need for these sort of measures. And again, that goes back to the fact that it was living memory of the MERS outbreak, which was so impactful in South Korea. On top of that, they had access, almost real-time access to data, which meant that their contact tracing facilities, their self-isolation assurance processes were much more robust. So people could be monitored by their roaming records, by their credit card records, and via CCTV. So there was access to big data. Now, people might say, well, the public health structure in Korea was very different to what it is here. But in actual fact, the KCDC looks very much like our own PHE. There's a national level organization with a regional footprint. The key difference is their delivery isn't at the local level. So the KCDC take the view, in my opinion, that their functioning is they work at the top of their license. So they don't deal with single cases. They don't deal with small outbreaks. They leave local authorities to do that, and they have trust in the local authorities to do that. But obviously, the requirement is that the local authority has IPC and health protection expertise in-house. It's only when you get large outbreaks or pan-provincial outbreaks that the KCDC steps in, and what happens is they have access to a flying squad, which goes in and shoe leather epidemiology, boots on the ground, assists where they can to break those chains of transmission. PHE didn't have such a function until the middle to late last year, when the rapid investigation team was brought into effect. And some of you may have seen that Christine Atchison, who's the lead, was featured in The Guardian a couple of weeks ago, and the story of how the RIT were instrumental in identifying the Kent variant is very eloquently put down. So I'd recommend you all have a look at that. It gives you a good flavor of how the RIT was used and what a day in the life of the RIT lead, Dr. Atchison, is. But I think it's important to point out that the key difference with South Korea and the rest of the world is the wider determinants of effectiveness. So these are things, I'm sure you've seen this framework, it's the PESTEL framework for looking at risks and opportunities when it comes to policies and interventions. It's a really good way of framing why South Korea, but also countries like Vietnam, who had experience of previous pandemics, were able to so effectively combat COVID-19. There's historical factors associated with it. So, example, in this case, the MERS outbreak, both countries had it. There was a political will and desire to make decisive actions, and very clear messaging was to be done. South Korea, for example, took the decision very early on that all comms would be led by scientists, and actually the key was transparency rather than public opinion. So it was put the message out there. And actually, the public opinion comes secondary as long as you're doing the right thing. There was strong economic incentives and packages very early on introduced. There was 3 main economic packages introduced by South Korea in the first 6 weeks of the pandemic, supporting parents with free childcare, providing financial support to those in self-isolation and quarantine. There's also societal differences. So South Korea is a very hierarchical but also collectivistic society. The needs of the society overweigh the individual. And again, living memory of MERS in 2015, so much higher likelihood to adhere to sort of NPIs. The other key enabler was the fact that their technological infrastructure and their legislative frameworks were aligned, in that there was almost real-time collection of data from multiple different sources, CCTV, mobile phones, GPS, credit card records, which were able, within the legislative framework of the country, to be used for the purposes of contact tracing and self-isolation assurance. Now, there was some pushback from the Koreans about this, and later on, the government did introduce a 14-day rule to reduce, to delete the data, but still, it was much more wider and far-reaching than would be acceptable, for example, in the UK or within Europe. And finally, there was also the public health response in Korea leveraged the full extent of the healthcare system there. And I'm sure colleagues may agree that it's been quite difficult to get public health messaging and public health initiatives into the NHS. There is the prevention agenda, but there's much more work we can do with NHS colleagues to get public health and the prevention agenda, and also public health responses aligned across healthcare, social care, and public health as well. I should say the vaccination program has been an example of where the NHS and public health have worked very well together. So maybe there are lessons learned that are being implemented. So what are the lessons learned from the pandemic response in Korea? Well, previous pandemic experience really is the best preparation, but it's more than just saying we've done it before. It's the fact that it aligns political, public, and system priorities. So everyone knows what to expect and what the consequences of not dealing with the pandemic properly are. It needs to be a system-wide approach, and that means applying the wider terms of health, but also engaging all facets of society. And finally, the responses need to be system and context specific. What that means is you can't just lift what one country does and put it elsewhere. This is basic public health principles, and that's because the social, legislative, cultural frameworks are different, and you may actually cause harm if that is something that you're proposing. The next thing I'm just going to talk about is testing capacity. So the WHO was very clear in March that they really recommend all countries test. But actually the approaches different countries took to testing capacity and increasing testing capacity was slightly different. So most of the data I have here is from Our World in Data. It's a really useful resource that really nicely and eloquently summarizes the findings and has some exemplar cases, of which Korea, Vietnam, and Germany are of those. And this is where most of this data comes from. So Korea and Vietnam had, let's say, the dubious benefit of having had experienced the MERS and SARS outbreak to some extent in the previous year. So they had robust pandemic plans in place. But as a result of the pandemic, they also had a vibrant and quite active biotech sector within the country. And what both countries managed to do was leverage this capability to push innovation within the development of testing capabilities for their use. So what the government did and what authorities did was they provided regulatory and governmental allowances to promote the development of COVID tests. And the fact it was locally sourced meant that they were somewhat mitigated from the global shortage of reagents, which had an impact in Europe, but especially in the UK as well. That meant that both Vietnam and Korea were able to ramp up testing capacity quite quickly. Germany, on the other hand, they took a different approach. And again, this goes back to what I said before, is that your response is really a child of the system that it's based in. So Germany has a multi-payer healthcare system around social health insurance, and therefore it has a wide network of highly advanced labs, public and mainly private, throughout the country, which nearly all have RT-PCR experience and capability, but critically, they have the containment facilities to handle hazardous goods. What the German government did was came in and mandated that all insurance firms must pay for COVID tests. This then introduced a market force of incentivizing these labs to quickly upscale RT-PCR testing, and therefore scaling up was profitable. So Germany's testing capacity also increased rapidly. And you can see that 90% of their testing capability now comes from private labs. Now, compare that to the UK. So in my eyes, historically, the UK's lab system can be split into a high throughput general NHS system, which we use for almost all of our healthcare needs, and a low throughput specialist PHE system, which we know as Colindale, the reference lab. To give you an example of capacity, Colindale could do around 100, 120 the viral respiratory unit tests before the pandemic. By March, this was 20 times higher. And it's important to point out that most of COVID testing capacity in the UK, or all of it, in fact, until about March, was from PHE and PHE's ability to scale up as quickly as possible. This was identified by PHE early on, and a rapid scaling program was introduced to help NHS labs pick up the skills and equipment to undertake testing. And PHE also lobbied HSC and the advisory group for dangerous pathogens to try and downgrade the containment level required for private labs to be able to undertake COVID testing. And while it did successfully do that in a safe way, what the eventual issues seemed to be was that private labs, although they could do the tests and had the right containment facilities, they couldn't match the requirement for end-to-end process. That means collection of results, collection of samples, analysis of results, and communication of samples back to the patient. And that's where a lot of private lab capacity wasn't able to be utilized because they couldn't meet those requirements. So what were the lessons from testing? Well, existing infrastructure determines what is possible, and if you want to move beyond that infrastructure, that has a time and cost penalty associated with it. Flexibility in legislation and regulations are enablers, but they need to be thought about quite carefully because it depends on what your tolerance for risk is. And this goes back to, it's no excuse to relax legislation or regulation if you don't have robust validation assurance processes in place, because what that can do is cause reputational and financial damage down the line. The next thing we know is COVID has been, the differential impact on COVID on different ethnic minorities has been quite substantial. And we know there's various reasons associated with that. One of them is engagement and communication with ethnic minority communities. And I think the experience of the rapid investigation team in Leicester last year was quite, can highlight this quite profoundly. So what happened? So while the rest of the country was coming out of wave one, there were signals in Leicester that infection rates just were still higher than the background rate. Leicester was still running hot, so to speak. And it was identified that most of these cases were in the eastern part of the city, which was where majority of ethnic minorities live, varying degrees of deprivation, mainly on the high side, and penetrative COVID messaging was low. The RIT was deployed at the time, and the issues that were, or the challenges that were identified were there was mainly structural and systemic issues in place. So the type of workplaces that were used by the transient migrant population were factories, places where social distancing couldn't really be done effectively, and where COVID mitigation actions, while in place, weren't being fully effective. There was issues around overcrowding in households because of the nature of the working pattern in the factory. It was shift pattern, so people who would come to work, people would share rooms in order to reduce their expenses. So what would happen is one would go on a shift, another person would use the room, and then when that individual shift finished, they'd come back home, and the person who they were sharing a room with would go to work. So this, again, perpetuated the cycle of household transmission among this group of individuals. While there was increase in testing capacity offered in order to combat the rise in cases, there was significant barriers to access. For example, the timing of when these testing centers were open coincided when most people were at work, so they couldn't get to it. The locations were far away from workplaces and living areas, so people wouldn't travel. And because there were military testing units at the time, there was a perception of authority which struck fear with some people, thinking that they may go in trouble if they were there, maybe if there were some irregularities with some paperwork. But actually, the overarching issue and overarching challenge that we found was sociocultural ones. And these included the fact there was a transient international workforce, limited English in Leicester at the time, very work focused, which means that their overarching aim at that time was driven by the fact they needed to do overtime to be financially secure, earn enough to have rent and send back home, multiple nationalities, multiple languages, limited engagement of this group with local services, a limited data footprint, and the way the RIT got the data was going around with local experts, local businessmen, local community leaders, and really highlighted the fact that actually local knowledge is really key in combating local chains of transmission. Most of the individuals, most of the at-risk population actually didn't get their news from local media or from standard media sources. They trusted their religious leaders and their employers as a source of information and guidance, and there was challenge getting those messages through to them to pass on. And finally, COVID mitigation messaging as a result wasn't well penetrated within that group. So an example of the comms that were going on in Leicester at the time, it was mainly, as would be expected, going through standard mainstream media, so BBC, the Leicester Mercury, social media, and we identified opportunities where the comms could be enhanced to highlight the key messages, but also make them target specific. So this is some of the examples that were going on. But again, unless you speak English, you may not be able to correctly interpret these. And even though obviously Leicester City Council and the DPH particularly were really involved in making sure the message was out there, it wasn't reaching the correct populations because they weren't able to correctly interpret it. So some of the findings and suggestions we did was was saying that, you know, the DPH and community leader needs to be the face of this. The messages need to be targeted to the correct community. It needs to be given through a channel that's accessible for them, and it needs to be given in a way that is socially and culturally sensitive, but also receptive. And again, rather than being targeting the entirety of Leicester, it needs to target the local communities. And actually, these aren't new things. These are the core basic public health. And interestingly, before this, 5B had published a paper that suggests the ways of engaging with communities. And these are things that public health experts and public health practitioners should always be aware of. You know, culturally appropriate and credible rationale for things that you're doing, engaging with the community, co-production, and using the current systems and structures in place to enable that change. And I'm pleased to say a lot of this was, a lot of learning, which Richard Amlow, who's the head of the BSIU at PHE, was involved in, was directly applied to the vaccine rollout. And I'm sure you're all aware of the big drive to have ethnic minority leaders push uptake in those groups. Finally, one of the things to talk about is as well unintended consequences of public health interventions. And for this, we're going to use the state of Kuwait. So Kuwait had a really robust response to the pandemic to begin with. What I'm going to do is run through this because we're short of time. So Kuwait had a really good response to pandemic to begin with. Lauded by the WHO for its response. They literally threw the kitchen sink and then some at preventing incoming transmission. The issue was that their focus was essentially on travel-related cases, and it overlooked the fact that local transmission may also play a part. And that focus led to policies policies and NPIs that focused on the external threat of incoming travelers rather than controlling incoming internal transmission as well. And what that does is the combination of lots of curfews, lots of lockdowns means you essentially generated a petri dish, as Sharifa Al-Shaflan of LSE put it, where there was huge amounts of local transmission caused by these overcrowded communities of migrant workers, which essentially meant that all the NPIs you put in place to control external introductions of COVID were moot. And what happened was, you could argue that that's because Kuwait had a limited public health system, and therefore there was limited recognition of health protection issues and health inequalities which populated this. But the counter to that is a similar shift to cases we've seen in Singapore. So as in Kuwait, where the shift of cases went from Kuwaiti citizens into migrant workers. The same was seen in Singapore. And in Singapore particularly, there was differential and unequal treatment of the migrant groups. Same was seen as Kuwait. And I guess the lessons learned, what I'm trying to get from this, is that all NPIs and all public health systems or public interventions have unintended consequences and will always introduce differential inequalities into societies. And Gus O'Donnell with the IFS annual lecture quite eloquently put this last year and said, when you're looking at how to implement NPIs and when you're looking at public health interventions, it's more than just looking at the number of lives saved or the morbidity. You also have to look at the wider consequences of the NPIs you put in place and the adverse effect that public health interventions may have on wider society. And Theo Lorenc and Catherine Oliver also showed this in an opinion piece last year as well. Finally, just the last bit on messaging, very quickly. The messaging, we can all be certain that it has not been great for most countries. Some countries, such as South Korea, all European countries, have been very clear, concise, and consistent in their messaging. But some other countries, UK, our favorite US president, Brazil, there's been a variation in the messaging that they've given, and that sometimes has caused doubt and has allowed there to be a increase in uncertainty from the population. Instead of reinforcing them, reinforcing the messages that have come through, they've cast doubt on it. And an example is when Boris Johnson said, "I'll continue to shake hands." And I think the best thing that reinforces this is, I hope this clip will play. Nope, it won't. But I'm sure you've all seen the clip of our favorite comedian showing a parody of one of Boris Johnson's conferences. So, in summary, if I can go to my next summary slide. There we go. So, in summary, majority of okay. We'll speak to it. In summary, the majority of countries who had a good response were based on decisions they made years ago. And I think it's really important to point out that a lot of these decisions were made in the context with previous experiences. And it's difficult to compare two countries to each other because the extent of differences in societies, but also frameworks of legislation and infrastructure means it's difficult to directly compare two countries. The most effective responses were those that activated all facets of society, government, and business. And in the UK, we're sometimes averse to bringing in the private sector, but we know that other countries have used it quite effectively. And finally, the fundamentals of public health shouldn't be forgotten. Things like community engagement, addressing wider determinants, accepting risk, and tackling inequality are things we should always pay attention to. So I'm sorry I've overran, but that is the end of my lecture, and I apologize for the technical issues that have been experienced as well.
Okay, thank you, Youssof, very much. That was a very rapid tour through some very interesting global and UK information. Colleagues have been appreciative of that in the sidebar. There's only one question, which, and we're a little short of time. It's quite a general one, actually, about which bits of best practice could we apply. So I sense that's not a simple answer to begin with. So perhaps if we can engage with that answer a bit later on, you can put some of that in the sidebar. And I'm going to move on to Liz. But Youssof, thank you very much. That was an excellent presentation. And I know that colleagues have appreciated that, particularly when they've been working on the front line to see that wider strategic overview. So thank you very much indeed.